Hi guys, Mark Kolbeck from Paramedicine.com here. Today I'm going to be talking you through a very basic, simple head-to-toe exam of a patient and giving you an idea of what it is we look for, what it is we examine when we're doing a head-to-toe. Now I'm saying this is a basic examination because there are other exams that will often build on to this one. If we think it's a patient with a respiratory problem, we'll do a full respiratory exam. If we think it's a neurological problem, we'll do a neuro exam. There's a cardiac exam. There are trauma exams. There are other exams that we can add on to this basic head to toe. But what I'm going to show you today is just a really simple, quick head to toe to see if your patient is okay. All right. So obviously we've got all our equipment. We've got our gloves on. Don't touch a patient without gloves. This is a general rule. Probably not such a bad idea if you're working clinically to have some goggles as well, just because, you know, people cough and blood splashes and people vomit and all that sort of stuff. So when I think about the head to toe exam, I go from the head down to the toe. So I'm going to break it up into sections of the body and talk about the different parts of the body and things to look for. I'm going to talk also about assessing for lesions. And lesions is a bit of a fancy medical word for something wrong. So deformities, contusions, abrasions, punctures, penetrations, tenderness, lacerations, swelling, burns, all those different things that can happen to somebody's body, all the ouchies. It's a great medical word. Lesions just covers all of them. So if I were to be examining this patient, here's how I'd approach it. I'm going to do and talk at the same time so that you get an idea of what I'm doing. First thing I'd say to the patient is, hi there, my name's Mark, I'm a paramedic. I'd like to do a quick head-to-toe exam on you and just make sure that your body is okay. Is that all right? I'm going to be looking for some injuries and any evidence that you might be sick. If they say yes, and I've got my consent, then I'm going to start thinking about the head first. And when I think about the head, I think about three major parts to the head. I think about the face, I think about the back of the head, and then I think about the holes in the head. So looking at the face, I'm basically looking to make sure that there are no lesions, there's no injuries. I'm also taking a look to see that the face is symmetrical. Normally the space between our upper lid and our lower lid, which is called the palpebral fissure, is the same size on both sides. Not in everybody, but in most people it is. There isn't a droopy upper eyelid on either side, and there isn't a droopy lower eyelid on either side. This is called ptosis. When one side of the face is droopy, ptosis is the word. We also take a look here for the nasolabial fold, and in most people you'll see a line there, more or less distinct depending on the person's face. And if they've had a stroke or if they have some CNS injury, like a Bell's palsy or something like that, you might see that one side of the face looks a little bit like it's been flattened. So we're looking for that. We're looking to see that when people speak, both sides of their mouth are moving equally symmetrically. And we're just taking a look then basically to make sure that the face is symmetrical. If you suspect there's trauma, you can palpate the face, but I'm not going to do that. I'm just going to assume this is like a mild patient, that I'm not expecting a lot of trauma. So I've taken a look at the face. If I'm worried about the head, if they might have had a fall or something like that, then it's a good idea generally to palpate somebody's head. Start at the forehead and just move your hands around, giving it a good squeeze. As long as you don't think there's any cervical spine injury, then you can move their head a little bit, lift your hands up, and what you're feeling for are soft spots or crunchy spots or depressed spots or a spot that makes the patient go, oh, that's really sore. And when you're done and you've moved your hands all around their head, just take a quick look at your gloves and see if there's any blood. If there is blood, then you can assume that they must be bleeding from the back of their head. That's the face, that's the head. Now I'm going to think about the holes. And I've actually started a bit of that assessment as I came in because I'm taking a look at the patient's eyes and I want to see if they have a midline conjugate gaze that's tracking. So what that means is that their eyes are in the middle of their eye socket, that's midline, that they're conjugate, so there isn't one like off to the side a little bit more, and that they're tracking, which means that as things move around, their eyes move together and take a look at you. So as I walk in the room and take a look at the patient, usually, they've heard you coming. You've got your equipment, you're kind of a visual sight wearing your uniform, and they'll look at you. And as you walk across the room, their eyes will track, usually as you're speaking to them. So midline conjugate gaze that's tracking appropriately. As I get closer, I can take a look at their eyes as they look at me and see if their eyes are jiggling a little bit. We call that nystagmus. So I'm looking to see if there's any nystagmus. Next thing I'm going to do is I'm going to take out my, my little flashlight. Please, in this age of really bright LED flashlights, don't use a really bright LED flashlight because they can really hurt people's eyes. If that's too bright to look into your eyes, then it's too bright to be looking or shining into the patient's eyes. So make sure you're using a flashlight that's comfortable and meant for looking at pupils. You can get ones like this from medical stores that have a little chart on the side, which I find super handy to take a look at how big their pupils actually are in millimeters. So I'll ask the patient to take a look at my nose, and I'll say, I'm going to shine a light in your eyes. I shine it first in one eye, and I shine it in the other eye. When I see their pupils initially, they should be roughly the same size. When I shine into one eye, the other pupil should also constrict. So this pupil, it's called the consensual response. So this pupil will restrict and that, or constrict, and that pupil will constrict as well. So both eyes should constrict when we shine the light in there. Shine it in the other one, and both eyes should constrict as well. Then I ask the patient to take a look at my finger, and I ask them to look far away, like as far as they can in the room, and then look back at my finger. And usually around this distance, the distance at which their eyes cross. And when they look at your finger closely, their eyes should cross a little bit, and the pupils should constrict. And that's called accommodation, and it's normal to see them do that. So I'm looking whether their pupils are equal and reactive to light, which we call pearl, and whether they accommodate. Now, be aware that some people have naturally unequal pupils. About 20% of the population has that just naturally. And now that I've told you that, you'll start looking at people, and around 2 out of every 10 that you see will have unequal pupils, and that's a condition called anisocora. So if you notice that their pupils are unequal, then you should ask them, is that normal for you? Are you normally like that? And if they are, then it's fine. They haven't had a head injury or anything. That's just normal for them. Okay. Now we'll look at the rest of the holes. I'm going to take a look inside the nose. I'm looking for fluid. I'm looking for blood. I'm going to take a look inside the ears and get right down and take a look right into the ear hole and make sure there's no fluid, make sure there's no blood. And then take a look, it's called otorrhea and rhinorrhea, or otorrhagia and rhinohagia. And then we take a look inside the patient's mouth. And we're looking for quite a few things when we look inside a patient's mouth. So if you want to jump into the neuro, one of the things you could do is ask them to stick their tongue out for you, and I'll explain why in the neuro exam, but it should come out equally and symmetrically. You can ask them to open their mouth and say ah, ah, and you'll notice that the uvula at the back kind of jumps up a little bit as they say ah, and the tonsillar pillars close a bit. That indicates normal nerve functioning. You can take a look at the sides there, the tonsillar pillars, make sure they're not infected. You can also take a look at the tongue itself, especially along the sides, and you can take a look at the inside of the cheeks to see if they've been chewing themselves up, possibly from a seizure. We talk about a seizure injury pattern, and that's one of the things we look for is oral trauma. Take a look and make sure all of their teeth are there. They might not have all of their teeth. If they are missing teeth, ask them if that's normal for them or if they've had trauma that has knocked it out. We can also take a look at the mucous membranes, so the lips here and the eyes, the inside of the eyes. Make sure they're a nice pink color and make sure that they're nice and wet, the way mucous membranes should be. If they're a pale color, then it might indicate a bunch of problems with oxygen delivery. If the mucous membranes are dry, it might mean that they're a little bit dehydrated. Okay, so I've taken a look at their face, I've taken a look at their head, I've examined their head, and I've checked out the holes on the head to make sure that we've got everything covered. I'm also going to be listening as I talk with them to their speech and making sure that they can speak correctly, that they're oriented to person, place, and time, that they have memory to distant, recent, and incident. And I'm also going to listen to the quality of their voice. Again, this kind of jumps into the neuro, but if they're talking to you like this, if they're talking like Batman, then that could be a problem with one of the cranial nerves. And if they seem to have a very hoarse voice, then you can ask them, Is that normal for you? Is that the way your voice normally sounds, or has it changed recently? And if they tell you it's changed, then that's something to keep in mind and report to physicians and think about again in your neuro exam. Okay, so we've taken a look at the head. Now we're going to move down to the neck. And I think of the neck in three basic ways. I think of posterior neck, lateral neck, and anterior neck. So the posterior neck, what I'm going to do is I'm going to feel from the occiput, the top of the head here, and I'm going to feel down the vertebral bodies as best I can, and I'm going to feel them sticking out, and I'm going to make sure that they're in a midline, and I'm going to ask the patient, just as I walk my fingers down them step by step by step, if that's uncomfortable for them. Then I'm going to go slightly to the side of the vertebral bodies, and we've got these paraspinal muscles, the top of the trapezius muscle, and I'm going to feel down the trapezius muscle, and I'm just going to feel, are the patients, kind of doing this and guarding their cervical spine, or are they relaxed and are they comfortable? Obviously, if I'm pushing too hard, they might start guarding, so it's a very gentle sort of touch. And if they are tensing up their neck, you can say, can you just try to relax your neck muscles for me? And feel down and make sure that they're not, tight and guarding. They should be loose, and the cervical bodies should be midline, and it should all be non-tender. Someone, kind of rubs the back of your neck a little bit, that should actually feel good. It shouldn't hurt. That's the posterior neck. As I come around to the lateral neck, a bit anterior lateral, I start thinking about the jugular venous distension, and I take a look to see how much JVD they have. When someone's standing, they normally have about a finger of JVD above the collarbone. When they're lying down, they usually have JVD up to the jawline or close to, especially if they're lying like right flat. And if they're lying at 45 degrees like this, it's probably 1, 2, maybe 3 fingers, roughly. And if they're sitting up and the JVD, instead of just being above their collarbone, is right up to their jawline, you got to ask yourself, why can't their blood get into the heart? Something's probably constricting it, maybe pericarditis or tension pneumo or bad asthma with gas trapping or something. It's making it difficult for the blood to get into the heart. I kind of think of it like a nightclub is full, and so the lineup is going up along the sidewalk. It's like that. I can see the lineup, so something's happening down here in the nightclub that's not letting the blood in. So I think about that with JVD. If they're lying flat and they don't have JVD up to the neckline, I think, where's your blood? You should have blood. And I start wondering why they might be hypovolemic. And are they hypotensive? What's their blood pressure like? Then I start looking at the anterior neck. When I look at the anterior neck, I should see the trachea roughly midline. And I need to palpate the trachea to make sure that it actually is midline. And I'll tell you why. Because we normally look to see that the trachea is midline, because if it's not midline, it suggests something like a tension pneumothorax, where one side of your chest is hyperinflated and the lungs have sort of squished over to the other side because of this big hyperinflated area, and that's moved the trachea over. But the trachea is fixed superiorly. So up here, the trachea doesn't move very much. So when the trachea moves, if you think about it this way, here's my trachea. If my lungs start to move, the bottom of my trachea moves an awful lot, but the top of my trachea up here doesn't move very much at all. So ideally, we'd be feeling the lungs to see if they've moved over, or taking a chest x-ray. But in the field, we can't feel their lungs, and we're certainly not taking a chest x-ray. So what we do instead is we go to the lowest part of the trachea that we can actually feel. And that's here, I'll be careful with my microphone, just here at the suprasternal notch. If you feel on your body, you'll feel these 2 little bumps. If you put your finger on those bumps, there's a U sort of in the middle, put it at the top of the U, and then slowly and gently, otherwise you'll cough, press your fingers in, and you should feel your trachea on either side of the fingers. If you do that on your patient, nice and gently, palpate the edges of the suprasternal notch, and then just gently roll your fingers in a little bit and move them just a bit side to side, the trachea should be midline. If it's not midline, if it's not equally between your fingers, then note which side it's going to and start thinking about things that might be causing like a tension pneumothorax. Okay? Next we go down to the chest. I'm a firm believer that you should visualize the chest. You should take a look at it. There's nothing more embarrassing than bringing a patient in, especially if they have chest pain, bringing a patient in and discovering that they've got like shingles or, the subcutaneous emphysema or something like that that you didn't see because you just chose not to take a look. Now, everything in context. If somebody comes in because they dropped a big box on their foot, they've got no other trauma, there's no loss of consciousness, everything else is fine, I'm happy to just take a look at their foot. I don't necessarily have to take off their shirt or open their shirt. So in context, if there's some sort of torsal problem, then yeah, we should be looking at the torso, anterior and posterior. So when I look at the torso, if I'm worried about trauma, I'll feel along the collarbones, just make sure that they're okay, and then I'll often just push down on the middle of the chest as well. I do that with the back of my hand because it's less invasive, especially to women, than putting the front of your hand down like this. So just palpate, and then I like to press on the ribs and make sure that they've got a nice flex and they're okay. I don't do this if I'm strongly suspecting chest trauma because it doesn't really prove anything. If I've got a mechanism of injury that suggests that they've hurt their chest, I'm not really going to be pressing it a whole lot because I'm just going to be causing more injury. But I'll often give a quick squeeze and I'll ask people to cough and ask them, does that feel okay? And that just gives me a bit of an idea about the musculoskeletal system. So what's the chest wall like? When I take a look at the skin, I'm looking for subcutaneous emphysema. I'm taking a look for rashes like shingles or any other sort of rash, taking a look for any sort of lesions. I'm taking a look as the chest wall moves with breathing to make sure that the whole chest wall is moving in and moving out at the same time and there isn't any paradoxical motion. I'm also taking a look, obviously, to make sure there's no broken ribs sticking out of their skin, because that's obviously a pretty ominous sign and something you don't want to miss. The other thing that I'll typically do, and I often do this as a part of my ABCs, is I'll take my stethoscope and I'll have a quick listen. And when I'm listening to the patient, what I normally do first is I just do a quick axillary listen. So I'll stick my stethoscope basically right at the bottom slopey part of their armpit, just ask them to take a deep breath in and out, and then again on the other side, a deep breath in and out. That's usually my initial sort of quick glance. If it sounds at all funny, or if I'm worried that this is a respiratory patient, then I'm going to do a careful, 6-point auscultation to listen carefully to the lungs. I prefer to do that on the back of the patient because, again, it's less invasive getting into their chest space. Also, there's less soft tissue on the back. And it's often easier to get to. You can just lift up someone's t-shirt and go underneath and have a listen that way without necessarily exposing them dramatically out in public. So that's the chest. That's what I'll have a quick look at the chest. Then I'm going to take a look at their abdomen. Now, in order to do a proper abdominal assessment and actually feel and palpate, the patient needs to be lying flat and relaxed and comfortable. I've seen people do, abdominal palpations on people who are sitting up and self-supporting their torso on a couch or something like that. And we need our core muscles to sit up. So if you're sitting up properly, you won't have a relaxed abdomen. I generally like to do my head to toe once I've got them on my stretcher. It's easier. But if they're lying comfortably in their bed or on the ground or something like that, and you want to check them before you move them, you can do it there too. But to check the abdomen, they really do have to be lying down. So I'm going to take a look at the general shape of the abdomen. People who are slim will have a bit of a scaphoid curve, like a bump and then an indentation and a bump. Take a look roughly how large the abdomen is. If it's very large, we wonder sometimes whether that's fat or whether it's ascites, fluid that's inside the abdominal cavity. And there's a quick way to tell for that, but it takes two people. So what we'll do is if it's just the patient, you can ask the patient to put their hand on their belly just like this and press a little bit. If you're there with your partner, you can have your partner come to the side and put their hand on the abdomen and just have it go in a little bit firmly. And then you put your hand on both sides and just tap one side. Just tap it like that. And there'll be a little bit of a pulsatile wave that goes across. If it's fat, it tends not to go right across, but if it's water, it tends to wave on both sides. So you can get used to that, practice how it feels. The other thing is that you'll notice it feels a little bit different. And I tell my students, imagine a balloon filled with water and a balloon filled with butter and tapping them both and seeing how that would feel. Now, the whole abdomen isn't fat, so it's a little bit different. It's not that solid, but it gives you an idea of the difference in the consistency. So we'll have a bit of a feel of the abdomen. I tend to do it by quadrants, and I put my hand on and I roll it. Actually, before I touch, one of the things that I'll ask them to do is I'll ask them to just gently cough. I'll say, can you cough like this? And the amount of vocalization they do when they're coughing also tests another cranial nerve, so you can keep that in your mind. But if they cough and go, oh, that's really sore in my belly when I cough, then I'm not going to be pushing a lot on their abdomen because it's tender. And I'll just assume that they have, or I'll just decide that they have abdominal tenderness, and I don't need to do any testing. We used to do a test, and we should not do it anymore, where we put our hands in, pressed onto the belly, and then let go and watch the patient's face. And if they went, ah, then that was called rebound tenderness. Do not do rebound tenderness. It is cruel and unnecessary punishment. And if there is something wrong in their abdomen, you're putting a lot of stress on it. You get the same amount of information by asking the patient to cough. Just cough gently. And if they're savvy to that and they know that that's a test, one of the things that you can do just to see if they've got a sore abdomen is you can bump the table a little bit as you're talking to them. And if they do have intra-abdominal bleeding or something like that, they'll go, ooh, as the bed bounces. So we can bump the bed, or we can ask them to cough, or just as we gently palpate, not deep rebound tenderness, just gently rolling our hands, kind of like this, across each quadrant and saying, does that feel okay? Does that feel comfortable? And as you do that, it shouldn't be uncomfortable if you do it slowly and if you're pressing gently. Then I press down on the umbilicus and I sort of feel around a little bit because the aorta comes right down through the middle of the umbilicus, a little bit to the left. And I'm feeling for a large pulsatile mass. If there is a pulsatile mass, then I'm going to think to myself, that probably shouldn't be there, and I'm going to very gently let go of it and not push anymore, because if it is a dissecting aortic aneurysm, last thing I want to do is go poking around at it. So let it go. Take a look for appliances that might be coming out of the abdomen. Take a look for scars from previous surgery. Nowadays, a lot of abdominal surgery tends to be keyhole surgery, laparoscopic surgery. So you'll see a hole here, here, and one in through the umbilicus where they put the appliances in when they were doing the surgery. You can, if you want, auscultate for bowel sounds, although it's very non-specific and there's no evidence that says that bowel sounds actually mean anything. So I tend not to worry too much about bowel sounds. If I hear them, often you can hear they're called borborygmus, the borborygmi sort of noise while you're talking to the patient. Then I'll note that borborygmi was present or bowel sounds were present, but I don't specifically go looking for them. The other thing that I've omitted here, because I never do it, is doing a cardiac auscultation. I've worked with cardiologists, and I thought I had a murmur once too. And the amount of detail and time and care that they listen for about 4 minutes in a perfectly quiet room after they felt for the apical pulse, so they can figure out by palpation where your heart is in your chest. Like, it's just really intricate. So I tend not to do it as a general rule. What I will do is, if I'm listening to the lungs, I'll have a quick listen over the heart, and if I hear a pansystolic murmur, or if I hear a rub, then I'll note that. So a pansystolic murmur, instead of sounding like wum tum, wum tum, sounds a bit more like whoosh, 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 whoosh. And that's obviously bad. Your patient will probably be a little bit hypotensive. It's, you know, they'll be in trouble if they got a big pansystolic murmur like that. Or a cardiac friction rub. And what that is an inflammation of the membranes around the heart. And you can mimic that yourself if you want. This is like the cardiac rub, as you'll hear it, it's kind of da, 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 da. There's also sometimes pleural friction rub. And this is what I was thinking of. You can mimic the pleural friction rub by putting your hand over your stethoscope and then just moving your fingers, your knuckles over each other, like that. And you'll hear that sound. So that's a useful thing you can do. You can also check for hepatomegaly. So anybody who seems to have some sort of potential liver trouble, if they've got big swollen ascites, if they've got jaundice, if they've got a history of alcoholism, there's a quick and simple way to test for hepatomegaly. Traditionally, what they do is they tell you to feel under the costal margin here, the bottom rib, and try to figure out using your hands where the edge of the liver is. I've never been terribly good at that, but a physician, as a friend, showed me a really neat trick. If you go down to the bottom of the xiphoid process, which is at the bottom of your breastbone here. Then there's a bit of a open space here, and it's soft in between. Put your stethoscope on that soft area, and then starting around the umbilicus, just start to stroke your way up the abdomen. And as you get closer to the bottom of the ribs, you'll eventually start stroking over the liver. And the sound will go from whoosh, 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 and when it drops from the whoosh to the you've just gone over the liver. And the liver should try it. If you've never done this before, it's pretty amazing how well this works. The liver should only be about 1 centimeter or 2 below the edge of the ribs. If it's longer than that, then we're starting to think about hepatomegaly. Okay, so we've done the chest and we've done the abdomen, and now we're going to start thinking about the pelvis. So the pelvis, generally, we don't visualize the pelvis unless we have a specific reason to. We just don't pull down people's underwear. So if there's any suggestion that there might be lesions, then we're going to take a look sort of respectfully, trying not to expose the genitalia, taking a look around the abdomen. We used to palpate the abdomen and push it down and push in and listen for crepitus, the sound of bones crunching over each other. For pretty obvious reasons, that's not a good idea. We don't want to go rubbing their broken bones over each other. I'm not sure why we ever actually did that, but I did it. We all did it. We thought it was a good idea. We don't do that anymore. One of the things we can tell by just simply looking at the patient is whether they've been incontinent, either incontinent of urine or incontinent of feces. That usually indicates a loss in their level of awareness for whatever reason. Makes me think about seizures or makes me think about head injury or something like that. And we also assess for priapism. Priapism only occurs in males. It's an erection of the penis. And one of the ways you can tell is, you can see it. A surreptitious way to examine for it is you say, I just want to feel down the sides of your hips, and then stroke your hand just gently across the back, and if you feel an erect penis, then that's priapism. Priapism suggests either you're doing your exam very well and they're very happy with your performance, which is unlikely, or more likely it suggests that they've got damage to their spine and they've lost autonomic innervation at the level of the genitalia, and so they get this spontaneous erection. It's an indicator of spinal injury. Then we're going to go to the extremities, the arms and legs. And when I think of arms and legs, I think about motor neurovascular. So I'm checking the motor, neuro, and vascular status. The quick, easy one is vascular status. So I'm just going to take a look at their fingers. You can do a capillary refill, squeeze the nails very gently and just see how quickly the red flush comes back in. It should come back in just a few seconds. Kids can sometimes have different reactions to that. For me, honestly, cap refill is nice, but I usually like to feel for a pulse. And if I can feel a radial pulse, that comforts me because I know that if they're getting blood to their wrists, then they're probably getting blood to their brain and their heart and their lungs and their kidneys. And that's what I really care about right now, because if they're not getting blood here, then that's going to kill them. So I usually feel for a radial pulse on both sides and make sure I've got one. Similarly, when I'm feeling the feet, I'll just feel for a pulse on the top of the foot and make sure they've got one. That makes me comfortable that they're perfusing well. I'll ask them to wiggle their fingers, I'll ask them to wiggle their toes, and they should be able to do that. So that's my vascular, that's my motor, and then I'll ask them, I'll take a look in their eyes and I'll say, just look at me and let me know what finger I'm touching. And I'll touch their thumb on one side and I'll touch another finger on the other side. Usually I use the thumb and the little finger because people don't always know the names for the fingers in the middle. And then I'll do the same with the toes. I'll say, can you just keep looking at me? I'm going to touch one of your toes. Can you tell me which one you're touching? And then I'll go and touch another one. You can touch a big toe or a little toe. And we've done our motor neurovascular. If I have any other concerns about their motor neurovascular status, I may ask them to move their wrists, move their elbows, move their shoulders, just see if they've hurt those at all. Similarly, wiggle your toes, wiggle your ankles, bend your knee, lift your leg up, and does that hurt in your hip at all? So you can do those tests if you want. As they move, that's a bit of a range of motion test. As they move, I try to see if they have any tremors while they're resting, or if they have any ataxia, difficulty coordinating themselves doing a move. I'll take a look at the skin and I'll take a look at the turgor, usually on the back of their hand. So I'll make a little bit of a tent and I'll let go, and you can try it on yourselves. It should be nice and springy. If it stays up, it suggests maybe that they don't have enough fluid in their body. Another thing I'll take a look at is the dorsal venous arch drainage height, and I'll explain that. It's such a simple concept, but it's a really useful one to know. If you take a look at the back of somebody's hands, usually you'll be able to see veins and they're a little bit engorged. So as the patient is lying down, let me lie this patient down flat. As they're lying down flat, you can see on this mannequin that they've got veins standing out here, filled up with fluid. Usually at a height about a fist above their hip, those veins will start to drain. So if I were to take this person's hand and put it straight up, you'd see those drain. So somewhere between here and down there, it drains. And usually it's around this high. So once the hand gets to around there, the veins will start to drain. And for me, that's like an indirect blood pressure for the venous system. Because when we take a blood pressure around the arm, we're testing their arterial blood pressure. This gives me an idea of their venous blood pressure. So if their hand is down and the veins aren't engorged, I think, wow, they're pretty dry. If they've got, poor skin turgor and dry mucous membranes, I'm probably going to be starting an IV and giving this person some fluid as long as their lungs are clear. So what I'm going to do then is when I lift it up, if it drains around here, I'm happy. If it drains just a little bit above, but not the fist and the hand above, then I think this person's dry. They need a little bit more fluid in their tank, and that's one of the things I'm going to check for. Similarly, they might have too much fluid in them. And the way we'll assess for that is by taking a look at the lowest parts of their body. If they're sitting in a chair, that'll usually be their feet. If they've been lying in a bed, around the buttocks, around the scrotum, and we'll see if they have edema. And we'll take a look at the edema and how much they have. If they're sitting in a chair, again, how high does it go up the legs? And we can press on the edema and let go. And if it fills right back up, that's one finding, or it might stay pitted, which is another finding. We call that pitted edema. It's good to report about whether it's pitting or not. So we look for edema. We'll take a look too. I like to take a look at the patient's fingers and see if there's any clubbing, which means they kind of end up being rounded like spoons a little bit. And if you take your fingers and touch the tops of the nails together, you should see a little space in between the nails at the very top of the nail bed where it attaches to the skin and the finger. That's called Shamroth's sign. And when people are chronically hypoxic, for whatever reason, the ends of their fingers are really far away from where all the oxygenated blood is, and the ends of the fingers start to starve and want more blood. So what they do is they make more blood vessels. It's called angiogenesis. And those blood vessels make the fingers swell out a little bit. If you look at them like this or like this, they look kind of like spoons. And if you look at them like this, they kind of look thick and puffy, and there's no little space between the top of the nails. Give it a try. So smokers, chronic anemia, anybody who's poor circulation, anybody who's got problems getting enough oxygenated blood out to the periphery, they're going to have clubbing. Then I'm going to come down to the feet, and as I'm checking the feet, one of the things that I imagine or remember to do at this point is to do a plantar Babinski reflex. And I like to do the plantar Babinski using my shears very gently. And what I do is at the bottom of the foot, I'm going to rub along the outside of the foot and then across the pad underneath the toes. So if this is a foot, I'm going to rub it like this up along the side and then across the pad. And as I do that in an adult, you'll see that there's a bit of a reflex where the toes will go like that. They'll just flick a little bit down towards, if they were standing, towards the ground. And that's normal. That's called a plantar reflex. If you rub your stylus, whatever you're using, up across and they go the other way, that's abnormal. Adults shouldn't do that. In little kids, usually are under 2, usually kids who aren't walking yet, that is normal. That's called a Babinski reflex. That's called the plantar reflex. So in kids under 2, Babinski is normal. In humans over 2, Babinski is abnormal. They should not be going up that way. Think about it this way. If I took a knife and poked it into you, you'd go, ow. You wouldn't go, ow, hit me more. You'd withdraw from it. You want to go away from it. So when we do that plantar, we should get a little bit of a downward flick. The other way to think of it is if their toes start going up, what they're doing is they're pointing to their brain and saying something's wrong with my brain, or the spinal tracts that are coming down. There's a problem up there. They should be going down. And that's your quick head to toe. So we do the head, we think of the face, we think of the head, we think of the holes. We go posterior, anterolateral, and anterior neck. We go down through the chest. And of course I missed it, and it's always important not to miss this. At some point when you're moving your patient around, you're going to be able to get a chance to take a look at their back. I usually do this when I'm auscultating. Make sure as you're doing the front, the chest, you remember that you need to check the back as well. And you're looking for lesions, you're looking for all sort of the same sorts of things that you were looking for when you were looking at the chest. So examine their chest, examine their back, examine the abdomen, make sure it's okay. Quick check of the pelvis. Then I usually go down the arms, motor neurovascular and clubbing. Go down the legs, motor neurovascular and edema, and plantar Babinski. That's your exam. Now it took me a long time to talk about that, but when you actually do it, it really only takes about a minute. So it's a really quick exam, and that is your basic exam. That's it. Hopefully that was helpful.